Good morning and welcome back to our next session in MPHA's annual conference. We're excited to have Kendall Penndorf, Program Evaluator with Partnerships for Health, and Aaron Elmer-Burke, Project Coordinator with the Maine Center for Disease Control and Prevention, speaking with us this morning about rural models of collaboration, strengthening supports findings. Before they begin, a couple of reminders. If you've been with us, you know these already, but if you're just joining, we are providing closed captioning, which is available beneath the video. And we strongly ask you to please take the evaluation that's available through the feedback button at the end of the session. And please do that for each of the sessions you attend today throughout the 3 days. If you have any questions for Kendall and Aaron, we will be taking them at the end of their presentation, and you can enter those using the Q&A button. But I think that's all for me. So Kendall and Aaron, take it away.
Thanks, Heather, and thank you to MPHA for having us today. It's been a great group of people and presentations to be a part of. Today, Aaron and I are going to talk more about the rural models of collaboration, which was part of what we called strengthening supports evaluation of the Maine suicide prevention program. Aaron, do you have anything to add?
Nope, I can just get started if you want in the next slide.
Yeah. We do just want to let you know that we have nothing to disclose in regard to commercial relationships. And then just a brief look at our agenda for this morning. We're going to chat about suicide in Maine. Aaron's going to talk about the Communities of Care Project and crisis services in Maine. And then we will switch over to talking about the evaluation results, and then time at the end for any questions. So I will pass it over to Aaron.
Thank you for having us, everyone. So I'm going to go over the suicide demographics as it relates to Maine. So in 2020, we had 224 people die by suicide. Maine's suicide death rate is higher than the national average and is among the highest in the Northeast. We know that the rate of suicide is highest among men ages 45 to 64. And white males accounted for 84% of suicide deaths in 2020. And so this slide, I do apologize. I messed up on it a little bit. So that should say 34% of deaths occurred among individuals between the ages of 45 and 64 years of age. And just populations at higher risk for suicide are veterans, LGBTQIA individuals, and Native Americans. And Kendall, you can go to the next slide. So from that, for many Mainers, we know, especially those in rural areas, that primary care providers, hospitals, and community behavioral health providers may be the only option they have, or the for connection to suicide prevention resources. So we know that many of Maine adults who have died by suicide did not receive the needed mental health care that they needed. So that is why we have the Communities of Care Project. And from that, there are 3 goals. And the first one is to offer resources to help providers reduce the risk of suicide among patients in their care. And so from that, we had the Learning Collaborative. So we partnered with Sweetser Training Institute to create a suicide safer care training portal. And so this portal was a way for us to offer free training in suicide risk screening, intervention, treatment, and support. And so the way it worked, we like to say it's kind of like Amazon. You would put it in your shopping cart, you would check out, it would be free, and then you could do the online training. So the next goal was to improve care and outcomes of individuals at risk of suicide through a quality improvement model. So we did this through the Zero Suicide, and Zero Suicide is just a quality improvement model to improve care outcomes in individuals at risk of suicide. And so we had 3 agencies. We called them the Practice Transformation Partners, who utilize the Zero Suicide framework. And from there, they created a leadership team to review and update policies and procedures, and also engage staff in system-wide training. So they did use the trainings from the Learning Collaborative I mentioned earlier, but we also were able to do some in-person CAMS trainings and things like that. And so the third goal was care transition through individuals at risk of suicide. And we engage with community agencies to identify and disseminate successful role models of collaboration and to integrate that follow-ups and contact and support and for those care transitions. And Kendall, you can go to the next slide. And so I'm going to go over just the crisis services in Maine. So Maine has 5 state contracted crisis providers around the state. They include behavioral health agencies, and they provide mobile crisis services and crisis residential, and it's actually in 9 public health districts. And some of the services include 211, which is a really great resource to call for literally anything, and they can connect you to resources in Maine. They have the Intentional Warm Line, which is a 24/7 peer support line, a domestic abuse helpline, the Wabanaki Care Line, and then many tribal domestic and sexual violence advocacy center lines. Kendall, you can go to the next one. And so from the COVID-19 pandemic, the Office of Behavioral Health launched the Strengthen Me, which is a mental health and resilience response to COVID-19. And that they really offered some great resources around recognizing stress. They have some great resources on getting outside. They have actually a trail finder, which I find cool because I'm a hiker, and just many other resources you can utilize. And then they have a helpline that you would call. And then Kendall, you can, I think the next slide is actually you.
Yeah. Thanks so much, Erin. So now we're going to transition to talking about the evaluation that we did. So I'm a program evaluator with Partnerships for Health, and we were the independent evaluators for the Maine Suicide Prevention Program. And like Erin described, the Communities of Care project, we had done a separate evaluation for each of the 3 components. And so this one covers that last one with the transitions in care. So in this evaluation, we wanted to document all the ways that health systems and mental health agencies around Maine are working together to ensure safe transitions in care following a suicide attempt or a crisis. So to that end, we developed a qualitative evaluation design to identify these collaborations and to document the work they were doing. And we were guided by the following 3 evaluation questions. We were looking for the emerging best practices that exist for care transitions. We were, looking to see if there were models that were successful for care transitions in Maine. And finally, we wanted to document what the characteristics of these successful care transition networks were in Maine. So data collection spanned from 2018 to 2020. This included an in-person focus group, and I think we managed to get in 1 or 2 in-person interviews in 2018 and 2019 before we transitioned to doing virtual interviews over Zoom in 2020. We used a structured interview guide. Mostly we asked interviewees to kind of walk us through what the process looked like when an individual is discharged from either an inpatient hospital stay or an emergency department visit to a community-based mental health agency, and kind of what factors facilitated or created barriers during that transition. We took notes and recorded at the focus group and interviews, and those were later transcribed, and we used a thematic analysis process to identify emerging themes. And now we will go through what we found from the evaluation. First up, we looked at what were the best practices for continuity of care. There are a lot of evidence-based practices that we found being used by the agencies and the health systems that we spoke to. The first was discharge planning. Ideally, this is a process that's collaborative. It involves the patient, their family, and supports where appropriate. the inpatient, or outpatient provider that responded to the attempt or the crisis, as well as the community mental health provider that they will be referred to. Another best practice that we saw within the networks that we spoke to was 24 to 48 hour follow-up. It is best practice that an individual who is transitioning out of a higher level of care have an appointment in the community within 24 to 48 hours. Evidence shows that that first 48 hours is a very tenuous time for somebody who's had a prior suicide attempt to attempt suicide again. But as you can imagine, it's difficult always to ensure that there is an appointment within that first 48 hours, either due to provider shortage or individuals who choose not to attend an appointment. During this time, numerous attempts should be made to connect with the patient by phone to keep the line of communication open. And finally, discharge planning includes the transfer of all relevant patient knowledge between providers. So systems should have, or these networks should have a formal system to share patient information to all relevant stakeholders in a real-time manner. And then next, we had 5 themes that emerged from our interview. So I will go through those one at a time and talk a little bit more about those. So the first theme that came about was strong mutually beneficial relationships. Interviewees were really passionate to tell us about how the success of a collaboration really hinges upon the strength of the relationships of the partners who are involved. They stress the importance that these relationships should be established well before a crisis situation arises. It shouldn't happen during a crisis that a patient or an individual is experiencing. Some of the partnerships that we learned about during these interviews were decades old. Secondly, all parties that are part of the collaboration should find the partnership to be worth their time and effort. In successful collaborations, interviewees described being able to rely on each other to provide complementary services. One of the best examples was a hospital system, an emergency department, who didn't have a social worker on staff. And they knew that they could call the local crisis service agency, and they would send somebody over to speak to a patient immediately in the emergency department. And then they stress the importance of anticipating staff turnover. There is a lot of staff turnover, and no relationship should be built on a single person. There should be multiple people in the organization that are responsible to maintain and build those relationships. It is important to have a point person that you can speak to, but it's equally important to spread out the relationship building across the organization. And this is just one of the really great quotes that we got. I'll let you all read it while I just kind of chat about it, but this quote, I think, highlights the importance of relationship building, and that it's not just a one-time activity. You don't just go and meet with somebody and the relationship's built. It's really requires constant reach out, constant maintenance to keep the relationship strong. And this quote, I think, also speaks to the previous slide where multiple people need to be actively involved. I really like this one because it stressed that it's not just the directors, it's not just the CEOs that should be involved, but really staff all the way down to front office staff can actively be involved in building relationships within these collaborations. The second theme was effective communication. This really goes hand in hand with the relationship building. Interviewees really felt that regular meetings are necessary. They acknowledge that everyone is busy, and especially during COVID, meetings look a lot different than maybe they did beforehand. but that the commitment to meeting regularly really strengthened the collaboration and prevented breakdowns in communication. Along with that, they felt it was important to establish clear roles, responsibilities, and expectations for these meetings. I think we can all remember a meeting that we've been to that was really like a meeting about a meeting, where you don't really feel like anything productive happened during that time. So they felt that, you know, you really want to make sure that people don't feel like their time is being wasted by attending a meeting or that their expertise is not being utilized. So clearly delineating these expectations and the roles ahead of time is really important to have a more focused meeting. And then also in between these scheduled meetings, it's really important to develop those informal opportunities for communication. So if that's, you know, an email or a phone call between meetings, that all the collaborators feel comfortable reaching out in real time to discuss, you know, patient care breakdowns and communication. And then finally, they felt it was really important to create a space for when disagreements happen among collaborators. So, you know, the best collaborations acknowledge that that these frustrations within the group and breakdowns are going to happen, and rather than just kind of devolving and dissolving, they actively create spaces and times for group members to kind of work through those disagreements. And this quote just kind of highlights, you know, that these disagreements are natural and normal, and you know that the best collaborations will prioritize reaching a resolution. So in this quote, you know, there was an issue, and people felt comfortable enough to reach out and kind of talk through it rather than just like let it simmer. So the next theme is a diverse stakeholder group with support from leadership. So we spoke with members of collaborations that encompassed professionals from a lot of different disciplines, crisis services, emergency departments, hospitals, police departments, and other first responders, local shelters, and other social service agencies. They felt that that was really important to get the buy-in from this large stakeholder group, because in the case of you know, mental health, every person in the group might have a different piece of the puzzle about how to interact with a single individual. Like a high needs individual might have contact with everyone who's in the collaboration, and by working together within their appropriate scope, stakeholders could work together to design a better plan for helping that individual in the future. It was also noted as important to involve law enforcement in these collaborations, especially dealing with mental health. Unfortunately, mental health can be seen as criminality, and that law enforcement and first responders often are called to respond to mental health issues in the community. And so they felt that it was important to include law enforcement to increase education about how mental health issues can be handled in the future for a better outcome for everybody involved. And finally, support from leadership was viewed as really important on many levels. Leadership allowed members to take time to invest in these collaborative groups, to attend the many meetings that are needed to kind of strengthen the relationships. Additionally, a lot of the collaborators we spoke to were leaders within their organizations, and they could really set an example for their staff about what it looks like to work collaboratively across different disciplines. And once again, a little quote, just kind of speaking to the importance of working across disciplines, and finding, you know, the people at the table who can really speak to what can be done, like what's possible within the group. So the next theme was shared information. As mentioned earlier with like discharge planning, it's so important that organizations within a collaboration have access to patient information as appropriate to the scope of their services. Interviewees and collaborations we spoke to used formal interagency agreements, electronic health records, and a standard release form to share information. These formal systems really contributed to fewer breakdowns in patient care during the transition period. Similarly, referral processes are also very important. For instance, if an individual screens positive for suicide risk in the emergency department, a formal release process can facilitate a quick turnaround time to meet with a mental health provider in the community and provide that provider with all of the information that they need to know to best help that person. And unfortunately, what we found is that sometimes, for lack of time, a lot of these, I don't want to say a lot, but some of the agencies didn't have formalized processes. So it was kind of like everyone knew what to do in these instances, but it hadn't been written down. And so the interviewees really stress the importance of taking the time that if you have a process, if you have a procedure that's really central to the work that you're doing, is to take the time to document that and have that in writing and make sure that all staff and all members of the collaboration know what the policy or the procedure is. And here is just a little quote talking about, this collaboration. They all shared a common release that was good for 60 or 90 days, and it allowed the group to discuss with the patient and how the community could better support them moving forward. And then finally, funding was a huge part about ensuring a successful collaboration. A network doesn't work without funding, but we learned that in the absence of direct funding to the collaboration, that there were a lot of ways that individuals found workarounds. This example is specific to the medical system, but due to billing policies, collaborators could find themselves doing work that was unpaid due to duplicative efforts with another agency. So collaborators stressed that it was really important to understand the complex billing system to be redeemed for the services that they were providing that ultimately are for the good of the patient. And then where funding is not secure, and where funding can be impacted by changes in administration or other priorities, collaboration should seek outside funding as much as they can, such as through grant funding, and applying to these grants is one way that collaborations can expand their services. And as I said, this is kind of very specific to the medical system, but in this example, collaborators were finding workarounds to get paid for the work that they were doing with patients that wasn't necessarily how the system is set up to gather or to pay them back. And those are our findings. And so here are mine and Erin's contact information. You can reach out to either one of us at any time to chat more. And hopefully there's some questions that came in that we can answer.
Thank you both so much. We do have some questions coming in, and as a reminder, if you have questions for Erin and Kendall, please put those in the Q&A. Can you elaborate a bit more on the informed consent process for data sharing that you used?
Yes, I think I can only speak to what interviewees shared with us. I think it was mostly having a shared, document that is completed by the patient, where they consent to having everybody who's involved in their care. I mean, I think there's consents where, you can have your landlord, they can speak to your landlord, they can speak to anybody who who the patient might interact with. So I can't speak too much to what that process looks like. But the best practice is that there is an informed, that the patient consents to sharing their information across a wide variety of stakeholders. I don't think that always is the case, depending on where the individual is at.
Great, thank you for clarifying that. The next question is sort of funny. I feel like we're always talking about urban and wondering if it can be translated to rural, but this question is wondering, your study focuses on rural models of care. Could this model be adapted to urban models? And, to that point, is there even a need for this model in an urban setting?
Yeah, I think, rural is very relative. Maine is rural compared to a lot. So I think we did have one group that was in Portland. So Portland, technically by Maine standards, is not rural. And that was one of the longest standing, I think, large groups that had been meeting for years down in Portland. So that included individuals from Maine Medical Center psychiatry. It included a lot of I think the Opportunity Alliance was in there, not to give away who was involved. But, so there were big players down in Portland that had been doing this work. And their example was that they really kind of, they had a regular meeting, and in each meeting, folks from the collaboration could bring up, hey, John Doe that I see on Preble Street a lot, he's really been giving us a lot of, he's really been taking a lot from a lot of the different agencies. And so they had an opportunity where they could share between them, like what had already been done, or, he doesn't respond well to men, or I wouldn't, and, this example was, I wouldn't send like a single woman to, meet with him, so I think it can work really well in an urban, or a relatively urban setting that Portland is, and probably even beyond. I think the point is just that everybody's working together and sharing the knowledge that they have about the individual, and taking time out of their, day to come up with a plan for future interactions with that person.
Yeah, and if I can jump in, also the zero suicide framework that we used for the 3 agencies is actually can be implemented at any level. So no matter how small your agency is, and if you're an agency and you're like, that sounds interesting, please reach out to me, because that is part of my job, and so I can answer any questions in that as well.
Thank you. That's really helpful. And contact information is on the screen for folks who want to reach out to Aaron about the program, and Kendall as well for any additional questions. We are running up against time, as we seem to be doing in all of our sessions. But I really want to thank you both, Kendall and Aaron, for being with us this morning and sharing your work with us. It's really important. So I'm glad to get it out in front of our audience, and can hopefully continue the discussion as we go. We will take a 10-minute break, and then we will be back for our next session. And that session, let me get my agenda in front of me. Whoops. Broken it. Sorry, usually I'm better prepared than this, but as I'm pulling it up, a reminder to please complete the evaluation that you can find using the feedback form. And then our next session, here we go, is on cultivating mattering. So please make sure you tune in at 11 with us then. And thank you so much.